Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for January 31st, 2024. Thank you for joining us this month. Our presenter today is Leigh Callahan. Dr. Callahan is the tenured Mary Link Briggs Distinguished Professor of Medicine and Professor of Orthopedics at the University of North Carolina at Chapel Hill. She is the Associate Director of the Thurston Arthritis Research Center and the Director of the OAAA Action Alliance, so we are especially excited to have her here today. She has extensive experience serving in senior leadership roles in national and international nonprofit rheumatic and musculoskeletal disease organizations, and in setting arthritis public health agendas. She has served on numerous grant reviews for the NIH, the American College of Rheumatology Research, Rheumatic Research Foundation, and other national and international foundations. She is currently a member of the NIAMS Advisory Council and a member of the Movement is Life Steering Committee. Movement is Life does amazing work to address health disparities relevant to today's presentation, so I encourage you to check them out if you're not familiar. Dr. Callahan has worked as an arthritis outcomes researcher focused on rheumatoid arthritis and osteoarthritis for more than 30 years and has published over 300 original research articles, book chapters, editorials, and reviews. She is a highly regarded expert in physical activity interventions for arthritis, social determinants of health and health equity, and the development, evaluation, and dissemination of evidence-based behavioral interventions. The title of today's presentation is Disparities in Hip and Knee Osteoarthritis Prevalence and Outcomes. Welcome, Leigh.
Thank you, Kirsten, and thank you for the nice introduction. It is a real pleasure to be here as part of the Osteoarthritis Action Alliance's Lunch and Learn series. These are my disclosures. I have no relevant financial relationships and do have grant support from both NIAMS and the CDC. Osteoarthritis is the most common joint disease worldwide, and it is estimated that 32.5 million U.S. adults have clinical osteoarthritis. The most common sites are knee and hip, which we're going to focus on today. Osteoarthritis most likely represents, a final common pathway of many different factors, including genetics, environment, and biomechanical contributors. It is also associated with substantial individual and societal cost. And social determinant and racial and ethnic disparities are recognized in both knee and hip incidence, prevalence, and outcomes. Today, I'm going to talk briefly about social determinants of health, focus on individual and community level disparities in knee and hip OA, talk about multiple social risk factors and arthritis outcomes, and racial and ethnic disparities in knee and multi-joint OA, and finally give a brief summary. I'd like to start first with this pyramid from the CDC, which looks at the factors that affect health. And I think it's always good for us to remind ourselves that at the bottom of the pyramid, the factors that have the largest impact are socioeconomic factors, including poverty, education, housing, and inequality. Up at the top, clinical interventions certainly contribute in counseling and education, but the bulk of the impact is from socioeconomic factors. What are the social determinants of health? According to Healthy People 2030, social determinants of health are the conditions and environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risk. And the little wheel on the side shows the impact of all these various social determinants on the individual in the middle. Individual level measures of socioeconomic status are often referred to as social position or compositional effects. And these include level of educational attainment, whether someone graduates from high school, college, or more, occupational type, often really broken down between managerial or professional occupations versus non-managerial occupations, income, including both an individual's income as well as household income or wealth, home ownership, and social class. Community socioeconomic status measures are often referred to as contextual effects, and these can include items such as the percentage of household poverty, which would be like the percentage of homes that are in a census block or census tract that are below the poverty level, percentage of residential segregation, the built environment, and including things like complete streets or access to various walking items, and then environmental exposures, whether someone lives near to power lines or other toxic exposures. These contextual effects can be measured through GIS, or also comparing things on the census tract that we can determine various deprivation levels. Many years ago, Sir Michael Marmot and Richard Wilkinson really examined social determinants of health and outcomes in the UK. And they have shown throughout time the role of poor levels of socioeconomic status associated with poor outcomes. And as policymakers and researchers try to understand why some societies are healthier than others, they've tried to pay increasing attention to whether the factors are distal or whether the factors are proximal. So, often in epidemiology, we think about this. If people are going down a river and you're pulling people out as they're drowning, could you make a bigger impact if you built a dam up above? This is a nice table from a paper by Jocelyn Bowden and colleagues, where they look at some of the various social determinants of health that I've mentioned and look at that in relationship to the social determinant on the left side, in the center, the contextual considerations relevant to the social determinant, and then examples of settings and places where these can be found. So for instance, on the top line, when you look at structural, individual, and socioeconomic position, as I mentioned earlier, those are things like income, education, occupation, and examples of settings and places would include workplaces, home, healthcare, educational. Further down, you can see behavioral and biological contexts, with the contextual considerations being lifestyle factors, such as someone's diet or nutrition and exercise, and then examples of settings being green spaces, sports facilities, neighborhoods. In this model, it puts together a lot of the things that have been mentioned previously about social position or individual socioeconomic status and social context. And so on the far left, you have the individual factors at the top, social position, and including not only an individual's current socioeconomic status, but their childhood socioeconomic status, their parental education, their parents' income, whether or not they grew up in a home that their parents owned or not. Then below social context, the items I've mentioned, such as percent household poverty and built environment. There are a number of confounders, mediators, and moderators noted in the middle that are applicable to both social position and social context, including personal factors such as smoking status, BMI, injury, and perceived neighborhood perceptions, as well as psychological influences. All of these have an impact on osteoarthritis health outcomes, including OA prevalence, OA severity and progression of disease, whether or not their radiographs are progressing, and other outcomes such as disability and pain. Now that I've kind of set the stage for the various ways that individual and community level variables impact things, I'm going to go through some of the data, and there are a number of papers in both knee and hip OA, and I will first present the data related to knee OA, where there are more data, and then I'll follow with the hip OA data. These first slides look at, this first one looks at individual measures that I measured. This focuses on education, fewer years of formal education, occupation, non-managerial occupation, and income lower levels. So on the left, you have those three different SES measures, and with the lowest levels. In the middle, it shows the countries where the data are from. For this particular slide, looking at incidence and prevalence, we have data from the US, Norway, Denmark, and Sweden. And then on the far right, we show information about increased, whether or not increased incidence of OA or increased prevalence is associated with fewer years of individual level measures of SES. And as you can see, regardless of whether you're looking at incidence or prevalence, and whether we're looking at a definition of radiographic knee OA, symptomatic knee OA, which means the person has both radiographic and evidence of OA in a particular joint, such as the right knee, as well as symptoms in that same knee. Looking at self-reported OA or ICD-8 codes, increased levels are shown with all the three measures of individual SES. This next slide looks at the same three individual level measures of SES, and the data are from the US, Sweden, and Canada. And on the far right, it's looking at health outcomes measured by either the WOMAC or a pain catastrophizing score, the KOOS, activities of daily living scores, or quality of life. And in all health outcome measures, poor measures are seen: increased pain, decreased activities of daily living, decreased quality of life, and a larger number of people reporting poor or fair health status or needing knee arthroplasty. All of those are associated with the individual level measures of SES. This slide looks at community level SES measures and combines looking at incidence, prevalence, and outcomes. There are fewer studies that focus on community level measures, and these studies looked at community level while adjusting for individual level measures. And in these, you can see studies from the US, UK, and Spain. The measures that were looked at were percent of individuals living in high poverty areas in census block groups, area level SES, social class levels, and deprivation levels. And as you can see, in all measures, whether it's looking at incidence, prevalence, or outcomes, there are increased OA outcomes with all of these individual community level measures of SES. So now I'm going to essentially show very similar data in hip OA, but there are fewer studies that have looked at hip OA. And these first slides look at the individual level SES measures with the same levels we looked at in the knee OA slides, and the same countries, again showing that there were increased hip prevalence and incidence according to education, fewer years of education, non-managerial occupation levels, or lower income levels. When outcomes were similar outcomes that were looked at with the knee, WOMAC scores, pain catastrophizing, and Euroqual measures. When we looked at, there were no studies looking at income, but studies examining education or occupation, or both. There were some studies that looked at both, showed poor outcomes with fewer years of education and non-managerial occupation. This slide combines incidence, prevalence, and outcomes together and focuses on the community level SES measures. These studies were either from the US or Spain or the UK. And it's noted that there was higher incidence and prevalence of hip OA, as well as poor outcomes, a higher Oxford hip score, more dislocation, and increased mortality with poor community level measures of SES. These next few slides are going to talk about multiple social risk factors and arthritis outcomes. These data are from the 2017 BRFSS sample, and they're from 17 states. They looked at 5 social determinants of social risk factors that included food insecurity, housing insecurity, financial insecurity, unsafe neighborhoods, and healthcare access hardship. In this, the outcomes were related to all types of arthritis, but osteoarthritis is the most prevalent form of arthritis. So the majority of these people would have had osteoarthritis. If you look at the slide in the navy blue, that indicates the people who had no social risk factors. So they created an index whether a person had none of these social risk factors or they had 4 or more. And as you can see, it's a dose response where if individuals reported more social risk factors, they were more likely to have self-report that they had arthritis, going from around 12% to almost 25% with 4 or more. The next slide looks at the people who reported arthritis and their reporting of various arthritis outcomes, including limited activities, limited work, limited social activities, and severe joint pain. Again, the same dose response is seen in this, that individuals who reported more of the social risk factors, particularly 4 or more, were more likely to have more limited activities and limited work, limited social activities, and social joint pain. This next slide, the next series of slides are going to focus on racial and ethnic disparities in knee and multi-joint OA. As you noted in the early slides I showed about social determinants, they were focusing on social position and social contextual factors. Race is not a measure of socioeconomic status, but there are often disparities when you look at health disparities according to race. There's little exploration in racial and ethnic disparities in knee OA incidence. The analyses have been done in the Johnson County Osteoarthritis Project, where they looked at joint-based and person-based analyses between Blacks and whites. And in Johnson County, which is population-based, they found no significant differences between radiographic knee OA when there was a Kellgren-Lawrence score greater than or equal to 2. They found no significant differences in symptomatic knee OA and no significant differences in severe radiographic OA with a KL score greater than or equal to 3. When knee OA prevalence has been examined according to racial and ethnic disparities, the NHANES 3 found that Blacks were 50 to 60% more likely to have radiographic and symptomatic knee OA. Johnson County, so this is prevalence, not incidence, it was found that Blacks had 13.9% versus whites having 6.6% severe radiographic knee OA, but there was no significant difference in overall radiographic OA or symptomatic NEOAs, and with this severe was greater than or equal to Kellgren-Lawrence of 3. And then differences in NEOA prevalence between Blacks and whites seem to be more profound among women. Some research indicates that Chinese women have about 45% higher prevalence of radiographic NEOA and symptomatic NEOA. And no difference was noted in NEOA prevalence between Mexican Americans and whites in NHANES 3. This is just a summary of the forest plot where they tried to look at meta-analysis of a number of studies where differences in OA pain and function outcomes were examined in looking at Blacks versus whites. And as you can see on the plot, the whites were much less likely to have poor pain and functional outcomes compared to the Blacks, summarizing all of these studies. And then when disparities in racial and ethnic in NEOA outcomes were looked at in the Osteoarthritis Initiative, looking over from 2006 to 2014, Black race was associated with high pain and depression at baseline and month 96. Black race was associated with lower physical activity and health-related quality of life, and findings supported that a multi-mediation model where pain and depression and physical activity were examined as mediators, that they mediated some of the association between race and health-related quality of life. And this is a study done by one of my colleagues, Dr. Amanda Nelson, in the Johnson County OA study where they looked at multi-joint OA, so large joint phenotypes, hip and knee phenotypes with hand OA phenotypes, and found that Black participants were much less likely to have hand OA alone or in combination, but they were more likely to have multiple large joints with OA. And this was true for symptomatic OA as well. So in summary, individuals with lower SES levels who have knee or hip OA have been noted to have poor health-related outcomes in the US, Canada, and Europe. Living in poor neighborhoods has been shown to be associated with greater pain outcomes in knee and hip OA and worse pain and function after total knee arthroplasty. And racial differences have been noted in NEOA outcomes, with Blacks having a higher prevalence and reporting higher pain severity, disability, depression, and lower physical activity and health-related quality of life. And more research needs to focus on OA occurrence and outcomes in other racial ethnic groups, including Hispanic, Latino groups, Asian, and Native populations. And I'm just going to close with this. It's another, this is a figure from the paper by Bowden and colleagues, where it shows examples for integrating social determinant health at various different points along the care pathway, so that we note that this is not just sort of a research exercise to look where the differences are, but that healthcare professionals and primary care individuals can be alerted to think about that individuals who are either in high-risk occupations or have lower levels of SES may need to act early to prevent OA onset, or have more education in the diagnosis phase, all the way along the path to thinking about if they still have pain, having more access to health services and social support, and incorporating issues around financial position. And I have a list of references that I'm just going to scan through, but then if somebody went back to the recording, they could stop and look at the references. And I'd like to close with thanking My colleagues at the Thurston Arthritis Research Center and the UNC Division of Rheumatology, Allergy, and Immunology, specifically Doctors Nelson, Golightly, Allen, Cleveland, Schwartz, and Joanne Jordan. Thank you.
Thank you, Leigh. That was incredibly informative and important for all of us to understand the breadth and extent of disparities and the impact that they have on people. And I wanted to, while we're waiting for people to put their comments or questions in the chat, I just wanted to leap from that last slide that you showed that had the care pathway. And I think, so much of the data that you presented from research does inform not only additional research, but clinical care. It also puts me in the mind of the work we do at the OA Action Alliance that extends clinical care out to the public and informing public health education, awareness, action. And I know some of the work we've been doing in the OA Action Alliance recently has been focused on addressing disparities in a couple of different directions. Can you share a little bit about what that looks like, what we've been up to?
Yes, I am delighted to do that. And I think you have a very good point. There's a real interface between clinical care and the community. And I pulled back up that slide, and as you can see, particularly in the yellow box with the lifestyle interventions, we focus a lot on trying to get arthritis appropriate evidence-based interventions out into the communities for everyone. We want to reach not only individuals living in urban areas or individuals who are more affluent, but trying to go to rural communities, partner with community-based organizations that serve those individuals. And I think a lot of our latest work around trying to put particularly Walk with Ease in the Spanish version into our portal, Camino con Gusto, and revamping our Spanish language resources and tools to make them more culturally relevant, and partnering much more so with the community to get that input is what we're going to need to do more and more.
Thank you. Yes, and that certainly speaks to the need to reach people from an OA management perspective, and that the disparities are not just in our experience of disease, but also in reaching folks with those management strategies that they can do in conjunction with clinical care or on their own at home. And I wanted to just take an opportunity to forecast the Lunch and Learn that we'll be delivering in August. For those who are interested in this topic, Dr. Ernest Vina will present on disparities in OA management. That's August, I think I just mentioned, so be on the lookout for that registration. And Katie put in the chat the link to the Spanish language resources that we have at the OA Action Alliance. They are something that we've done recently. Check those out, and they also go hand in hand with our Walk with Ease portal that Leigh just mentioned. So shameless plug there for those resources. If anybody else has any other questions, we're happy to take those. We have a thank you from Charlotte in the chat, Leigh. And thank you, Charlotte, for tuning in.
Yes, and
go ahead.
I was just going to say, you shouted this out at the beginning, Kirsten, but the Movement is Life does a lot of work in this space, as well as the Osteoarthritis Action Alliance, in trying to get populations where they are and meet them with the lifestyle interventions and various programs that they need. So shout out to Movement is Life as well.
Absolutely. Thank you for that. And then I do have another question in the chat that I'll pull up, but I recognize the time. And for anyone who does need to sign off, I just want to give a quick forecast to February's Lunch and Learn that will be delivered on the 21st at the usual time of 12 noon. Ashley Buck will be delivering a presentation on evidence-based dietary practices for osteoarthritis management. So be on the lookout for that. Hope you can join. Also, before you head out, do please fill out the poll that we just popped up here. While you're doing that, I will ask this last question, actually from Ashley, thank you, that she says, fantastic presentation and is curious to hear more about your perspective and thoughts, whether there's any data on how different socioeconomic status subgroups respond to these lifestyle interventions. Do we need to tailor OA interventions to specific SES subgroups or otherwise?
That's a great question, Ashley. And actually, I'm going to give, since we've done so much work with Walk with Ease, I'll give the example there. We looked at, in Walk with Ease, we were very specific and tried to reach counties across North Carolina when we did the first evidence-based study. And so we were getting rural areas and tier 1, 2, and 3 areas. And then when we looked at outcomes according to individual level measures of SES, we found that we saw improvements both across the board. And when we did Camino con Gusto, we did the study on that with 385 Spanish speakers and looked at, did we see change? And in that group, we really had some individuals who had less than an 8th grade education. And we saw that we did get improvements across those. So, and we also looked at stratified by Blacks and whites in the original Walk with Ease study and found positive outcomes. So I think many of these arthritis appropriate evidence-based interventions have been developed to work across SES levels. And so now it's just getting them into those individuals' hands.
That's a great point. And as an extension to that, we've also done similar work in terms of tailoring some of our resources. In part, that's why we developed that Spanish language website and tailored some of our messaging and using videos and images and actually reaching out to the community members that we are trying to reach to ask them directly, what is it that would help you be more successful? How would you like to receive information? So I think that's a great point. One more question. Thank you, Leigh. I am a PM&R sports physician in New York. Could you please provide a link for home exercises for OA in Spanish if you are aware of any? We can certainly do that.
Yes, we can do that. And just to note, the portal, which has exercises in the and is a self-directed, Camino con Gusto is a self-directed walking program, and we have it in Spanish. It is individuals can go to our website and if they want an electronic book, they can get that for free. And we have it where they can choose to get text messages or emails, because we have heard that many Latinos do not want emails, and we're happy to give you a lot more of those resources and let you know what's available, because we want to distribute that as widely as possible.
And thank you for Katie being on top of things. She put the chat in, put a link in the chat to the Community con Gusto program. We're happy to help out with those. So a couple of thank yous have come in. No additional questions that I'm seeing at the moment. So I'll just thank everyone once again for joining us today. And thank you, Leigh, again for a fantastic presentation. And we hope to see everybody in February. Have a great day.